Hi, today I will discuss about the quadrilateral socket and its biomechanical limitations. In the last video, I discussed amputation, challenges to prosthetists, persons with amputation and limitations. It is available on this YouTube channel. The link is given in the description below. In the second video I discussed about normal physiology of body weight transfer. It is also available and link is given in the description. The quadrilateral socket was famous between World War I and World War II. Throughout history, transfemoral design and fabrication techniques have been passed down from mentors to proteges, with no formal instructional courses available until 1949. The University of California at Berkeley introduced a short course in the transfemoral design of a suction socket in 1949. In the 1950s, several universities began formal education programs in prosthetics, with each school creating their own laboratory manuals and design iterations. In the 1980s, the first ischial containment manual emerged and was quickly adopted by other institutions, although each institution implemented design iterations. The following biomechanical limitation is found in patients with quadrilateral socket. First, abduction gait. Second, lateral trunk banding. While the prosthetic foot is in the stance phase, the spine bends towards the prosthetic side. Because mediolateral stability is not controlled with the quadrilateral prosthetic socket. Biomechanical limitations to the patients with quadrilateral socket are due to 1. Lateral displacement of the femur due to active concentric contraction of the gluteus medius. 2. The distal end of the femur is covered with the soft muscular structure, therefore the scope of pendulum movement of the distal end of the femur. It leads to hip drop. 3. It's are compensated with the lateral trunk banding or abduction gait. The weight is transferred to the femur through the hip joint, however, the weight is transferred to the prosthetic socket through the ischial tuberosity, which is medial to the hip joint. Therefore, the residual stump did not participate in the weight transferring mechanism in the quadrilateral socket. Since 1969, it has become increasingly evident that quadrilateral sockets have serious biomechanical problems. And we are dealing with a pathomechanical situation when we consider the case of the above-knee amputee. No longer bones and ligaments are positively connecting the hip to the floor. We will discuss in the next lecture about intervening pseudo-joint, the patient-socket interface. Subscribe to the channel and click the bell icon to get the notification of the upcoming lectures.